to everybody, and particularly those who haven't joined our monthly sessions here, and happy 2021 to everybody. For those who I haven't met, and I see a number of people I recognize here on the call, my name's Catherine Donnelly. I'm the Director of the Health Services and Policy Research Institute here at Queen's, and we are thrilled to have Dr. Walter Wodchis here with us today as we kick off the new year. And particularly, I see a number of people on the line who are intimately connected with our new Ontario Health team here that we're working towards. And Dr. Wodchis is going to be talking to us specifically today about OHT's evaluation, which we're very keen to hear. For those of you who don't know Dr. Wodchis, he's a professor at the University of Toronto at the Dalai Lama School of Public Health and a senior adjunct scientist at ICS in Toronto. His research is focused on health economics, performance measurement, and evaluation. He's been highly involved in the OHTs, and I know he's going to reveal to us some of those early indicators that we've been waiting to hear about. He's also, that builds on his work that he's been connected with HealthLinks. So Walter, I'm going to hand it over to you, and we're excited to hear your talk today.
Oh, thank you very much. And I see that you do have quite an audience today, as well as some very esteemed attendees. So I'm in the hot seat. But it's a good group to talk with, and I'm really happy to start off the year with this conversation, and let you know a little bit about. I'm going to start off by positioning some of this a little bit in the recent history. Sorry, Duncan, not going back into the older history of Ontario innovations, but the recent history and innovations around care and how that might relate to Ontario health teams, and then I'll get right into how we're thinking about evaluating health teams, and also how we need to be thinking about transformation in the health system. So that's how I'm going to cover off. I'm going to go with my slides, and I'm going to pause at a couple places along the way, but feel free to use the chat all the way along. I'm not going to monitor slide to slide, but there are some places I'm going to stop and go over and check out the chat and come back on, and we can have a good discussion. I prefer not to be flipping back and forth too much. Okay, so here we go. And hopefully that is on the full screen version. Someone will come off mute and tell me that it's not. Welcome. And today I'm going to talk about Ontario health teams. And we're going to get to this point of what does success mean, and what we're thinking about, and how do we know if we're progressing towards that goal. And I'm speaking today as the central evaluator for the Ontario Health Team Initiative and out of the Health System Performance Network. So key takeaways. We take feedback all the time, and you may know we run monthly webinars related to OHTs, and one of the webinars we had in November had a lot of content, and someone said, that was just a lot. Can you just tell me what the takeaways are? So you might find today I've got a lot. So here's the takeaways, and for those people who get called out of the room to do other things, you can go after this slide. So the first stop is talking about why we're trying to implement Ontario Health Teams. And that's a little bit about the context. And I'm going to not sound the alarm because it builds on work that other people are doing, but the notion of increases in healthcare demand is not going away. And I explain a little bit about this. And you're going to see it tied very much into population health management later on. Then I'm going to talk a little bit about what does success look like, and use a quadruple aim framework to talk about that. And that's how we're thinking about success for Ontario health teams. And then finally, some thoughts around how would we know if we're progressing towards this goal. And at this point in time, we're very early days. This year, the Kingston Frontenac Lennox team was just approved very, very recently. So what can we say before much has really actually happened on the ground? And I'll say that vision and spirits are high, and technology and resources are low. So that's going to be where we end off. So we're going to start off actually with a poll, just so we can get a bit of readiness around, because I allude to these different pieces along the way. And Sherry's going to put this up as a true poll, I think, about what you know about some recent initiatives that have been evaluated in Ontario: HealthLinks, integrated funding models or bundled care, and Ontario health teams. And I'm hoping that there's pretty wide awareness, at least of the last, but I just want to get a sense of what people know about these prior initiatives, just if you're aware of them. It doesn't have to be in depth. And I'll leave it to Sherry to kind of see when we get at least sort of 80–90% of the respondents in on these, and you can click all that apply. Appreciate that.
Okay, I'd say we have just about everybody in.
Perfect.
We have only 10% that say they're not aware of any of these initiatives. 90% are aware of Ontario health teams. 45% are aware of integrated funding models and/or bundled care. And 66% know about health links.
Okay, well, that's good to know. So it will be useful for us to think about some of these past initiatives, and I'll allude to them, and that just gives me a little bit of an awareness of how much to talk about them. So I'm going to start off by saying, why do we want to be doing Ontario health teams, just in the sense of why transform care? There was some early work done at TD Bank that led to this graph that was then copied by the ministry about 5 or 7 years ago, around thinking about escalating costs into the future and health costs by 2030, and thinking about just the demographics alone. And I'm going to say we're going to be challenged by more than just demographics alone, would lead to escalating healthcare costs, particularly in the older ages, as we have many more people who are reaching that age where they need more care in order to continue to live their lives in a healthy way. And that's just through the natural aging process. And that isn't going anywhere. We continue to age. So there's a little bit of fear about this that motivates. Then we had done some data, and I put the original. I like going back to this original slide. It actually looks quite the same today, where we really know that there is a large concentration of healthcare costs among few users. Even in those older age groups, there's still a small proportion of the population consume most of our healthcare costs. Many people, and it's great news because most people are going around quite healthy over the long term. But the real thing that this is not actually a useful tool in terms of being able to manage population health or being able to do clinical interventions. It does two things for us. One is it highlights, hey, we need different kinds of care for different kinds of people. So the kind of care that we might have in the lower 50% of the population is different than the kind of care we might need in that top 5%. And just in case people hadn't seen this graph before, I just assume everybody's seen this by this point in time. But what we have here is we have the population of Ontario on the left side, and all of our healthcare system spending on the right side. And what we do is we say, we line people up and we order their costs so that in that left bar, the people who spend zero, didn't see a healthcare provider in the last year. I'm fortunate enough to be in that group. We are at the bottom of that left bar, and the people who we're doing lung transplants on, they're at the top end of that bar, or people who are in long-term care over the entire year and possibly being admitted to hospital. So that top 1%, and then we look at how much of their entire budget gets spent there, and it's 34% in that top 1%, and 2/3 is being spent in the top 5% of the population. But then we're really only spending like 1 to 2% of our healthcare dollars for that entire bottom 50% of the population. So it just tells us we need to think differently about different population segments. And one of the things we might want to think about are who are the people who may have high costs that are sustained over time. So we do a lot in our healthcare system. In fact, the most we do in our healthcare system, aside from pandemic times, is elective surgical care. So things like hips and knees and cardiac surgery are at the top of the list. But they're going to be one time, hopefully. And we want to know there are some people at the top that we're going to continue to spend large amounts of money on. And how do we think about caring for them differently to ensure that we're getting the maximum value out of those healthcare inputs? Here is what I think is actually really going to drive our challenge, though. And that is multimorbidity and the prevalence of multiple chronic conditions. And our original paper with the first two graphs here was out in 2015, and we just have an update that's hopefully coming out soon in Canadian Journal of Public Health. And what this is each of these graphs shows the entire population of Ontario by age only, and that's the gray section in the background. And then we show how many of these people have 1, 2, 3, 4, or 5 or more chronic conditions. There's a set of 18 we're looking at here, which are very common. And the interesting thing here is if we look over time, so in 2003, we had a quarter of our population with 2 or more of these 17 conditions. But by the time we got out to 2016, it's over 30% of our population. That is continuing to trend. And this is, I think, where the demand side comes in. So it's not about how do we care for people, This is about people's diagnoses. And then on top of that, we think about how do we address these needs? Are we doing it disease by disease? Are we going to think about different combinations of conditions? And perhaps we just need to think about a more person-centered oriented approach when we have people who have 3 and 4 conditions, some of which the treatment actually may counteract and be antagonistic. So that horizontal bar just shows that. This upper bar shows how many people back in 2003, the top end of the people with 5 or more chronic conditions. And then you see how many more people have jumped that bar over the intervening 15 years. And this is continuing to escalate for many reasons. One is increased diagnoses, but another is actually health habits. The thing that astonished us is how many of the people are rising up in their 40s and 50s in this area, not just the oldest age groups. It does peak in the oldest, but there are lots of in the younger. So this is not going away. Why is that important from a policy perspective? So clinicians involved here would all understand that, especially primary care physicians. But from a policy perspective, and I think this is a policy group, we're often interested in where spending is. So it turns out that 68% of all public health expenditures in Ontario in 2009, and it's still true today, was associated with people with 2 or more conditions. So that 70% that I talked about before, those 2/3, and these are the people that are going to continue to be incurring costs over time, are for these people with multiple chronic conditions. And hospital care does remain the primary cost driver regardless of age group, and healthcare costs increase. They're more than simply additive with the number of conditions. And that's shown a little bit in this graph. You can see I like this style of graph. So up at the top, for the top, the 2.68% of the population that have 5 or more chronic conditions, we're spending 20% of our dollars. For the roughly 5.5% that have 4 or more, we're talking about 33% of our healthcare spending. And in the people with 2 or more, that's that 68%. So this is where our dollars are going. And the people at bottom 50% of the population consuming in total, it's a lot of people, but in total about 14% of resources, those are those people that I had earlier on that have very few conditions and are just doing maintenance care with the health system. So I'm going to say that the incidence of chronic conditions is the issue that is going to continue to magnify over time and continue to drive our healthcare spending. So what are the policy responses to this? Well, there was a report, the Drummond report came out, and it talked about some of the initiatives, and actually that's where this data come from that Helen was presenting on, Helen Angus in 2013. And there's a reduction of 10% in the costs of patients in that top 5% could save $2 billion. And at the same time, too many people were receiving care in the hospital, could be better cared for in the community. Many people not getting the benefits of a coordinated care plan, and wait times for specialty services in long-term care homes were just too long. But this notion of saving 10%, I call that speculation, because we didn't really have a plan for how we were going to extract those dollars or actually generate savings. And I'm going to talk mostly about value as opposed to savings, because I think that what we need to think about is how do we ensure that we get the entire population health improving as much as possible, and that we generate the greatest value at the individual and the population level. So that's a bit of the background coming into here. And then we have these ideas. So I talked about coordinated care. Well, there's a couple ways the ministry have thought about that. That's up in Community Health Links in the left corner there, launched in 2012, and was an initiative running for many years in the area of better coordinating care, first for people who are high cost, and once people realize that that's not an identifiable group, then the people who have 4 or more chronic conditions. And that's agreement, I say, with some of the work that we had done on that research. Another area that people have been working in is this idea of integrated care funding models or bundled care. And this example here was brought through an integrated funding model pilot program, which I won't get into details, but we've done some evaluation of. And then that spanned to cover all hip and knee, and soon moving to cardiac and other spinal and orthopedic surgeries in the near future. So really thinking about how do we package things together as opposed to paying all of the individual providers separately. And that's those 2 initiatives. And now this one in the center, we need to come up with a better graphic for for Ontario health teams, by the way. So I'll challenge our ministry people to do that. Because what it says though is that in the current state, the individual patient is still encountering, despite these other efforts, these different parts of the healthcare system entirely in isolation. And the notion of a health team is that we're not going to try and coordinate the care. We're actually going to bring these providers together into the same group. And that's this notion at the bottom where everybody is actually part of the same group, and patients are receiving all of their care, mental health and addictions, long-term care, home care, all from the same team. And that's the real transformational difference that Ontario Health Teams is. We're not trying to tinker at the edges anymore, but we have a vision for long-term, true integrated service delivery models. Well, what does this mean in terms of how do we get there? So here I've got, and some of the rationale as to where some of the other thinking comes from, how we ended up here. So this is a graph that we had produced around the time of bundled care and thinking about what are the different types of services. So you can think about seeing your fee-for-service physician down in the bottom left corner, one provider, short-term encounter. You have a short stay acute care, that's an acute DRG. But then as we start to move to other conditions, we can go straight vertically and have longer time for singular conditions and providers, that's around dialysis care. Or we can start moving out to chronic disease management, maybe more inclusive care for the elderly. And that's the notion of these bundles. I'm going to say that this is two-dimensional transformation. We're thinking about how many providers do we bring in and over what span of time do we start to hold them clinically and financially accountable. And I'm going to say that that's insufficient. The idea of the bundles comes really out of Michael Porter at Olmsted, and he's written about this a little bit, mostly in the US, but it's filtered across the border. And the amazing thing here is that it's the strategy that will fix healthcare, which is a pretty bold statement. I wish I could write a paper with that title. And I'm going to argue that that's still two-dimensional ideas. They're thinking about just a package of a certain set of providers over a specific set of time. It is a step forward from where we're at now, but I think that it's not sufficient, and that what we're going to need is three-dimensional transformation. Now, I've only worked this up like just last week, trying to think about how do I convey this. So the graphic here is not great. But the idea is that we need to move beyond the span of providers and time to think about patient-based populations. So going back to the beginning of the different population groups, lower cost users, higher cost users, or people with one chronic condition, people with multiple chronic conditions, we need to think about each of those populations separately as we think about combinations of providers and time. And I'm going to call that three-dimensional transformation. And OHTs are heading towards this by having different population-based models. So you could think about thinking about bundles for children, for youth, people with disability, people with chronic conditions, multiple chronic conditions, healthy older adults, frail older adults, end-of-life care. And this is starting to move towards three-dimensional transformation. And that's where the notion of having both integrated care and population health management are going to come to the fore. I'm not going to talk a lot about population health management today. I'll just allude to it, but we will have webinars coming up as part of our OHT series on population-based management. I will say, related to population-based management, that you could think about the entire ecosphere, macro, meso, micro, as having many layers, and this is a Population Health Alliance framework adapted by colleagues in the Netherlands. And it starts out by thinking about what's the entire population at the top, and then thinking about how can we do maybe a triple aim assessment of our entire population. And I'm going to argue for quadruple aim assessment, but they had laid it out as three: population health, quality, and costs. And then thinking the next step is to segment the population. Here it's very simply done as no or low risk, moderate risk, and high risk. But starting to think about, okay, how are we doing overall? And then within these risk strata, how are we doing? And I'm going to say that those risk strata need to be clinically meaningful. And by having clinically meaningful stratifications of populations, then we can think about citizen-centered or patient-centered interventions where we have some health promotion, some risk management, some care coordination, disease or case management, or end-of-life care, depending on the needs of that population. And that's where these start to tie together. And then thinking from there, what's the evaluation? How are we going to impact? How are we going to evaluate the impact of these? And also using a quadruple as opposed to this triple aim framework. And then from there, depending on how we're doing, building a quality improvement process that may go back to any one of the levels. It could be we didn't actually understand our population well in the first place. Or do we have the right measures to monitor outcomes? Or do we need to improve the way we risk stratify to make it more meaningful? or do we need to improve the way we design the match of the interventions to those populations? So these are the demands, and moving from those individual projects we've done in the past around the need and getting to both population health management and integrated care. And here I'm going to pause and go over and check out the chat, turn that option back on, and just see, how do you reflect at this point in time about, do you agree multimorbidity or other challenges? Maybe you have other ideas about some of the big population level challenges. And what do you think about this notion of having different population programs? And how are we going to balance ideas from specific initiatives around target populations and population health management? So I think I have stopped screen sharing. I can see it now, and that lets me go over and kind of check out the chat, which looks like it's been pretty quiet actually. So feel free to come on screen. There are, I guess, 60 people, so hopefully that works, but use the chat as well. So let's just see how people are doing, and I might need Sherry's help, but how do you reflect on just the setup here for how do we get into OHTs, and what are we hoping to achieve around the OHTs? Agree, disagree? Think we've missed the mark here? How to move from, yeah, go.
No, sorry, Walter, just help me with the chat, but you see it too, so I will stop talking.
Okay, yeah, I'll be able to see the chats. How do we move from illness-based health to more health-based interventions? And that is, I think, going upstream. And to me, that's this balance. And that is by starting out and thinking about the entire population, an attributable population. And ultimately, it might be more geographically based. Right now, we're using a bit of an attribution model, which has geographic elements, but is not purely geographic. And thinking about those people even before. So where are there some gaps? So other places that are doing population-based management, they do think, individually within these groups, they can actually get down to a disease-based approach and say, in diabetes, where do we have people that are not meeting their markers, and how do we help them? Because it's not always about seeing the doctor. Sometimes it's about having access to food or being able to have transportation issues to manage those conditions. And what about the people with multiple? And that's where this population assessment comes in, and that should be the thing that drives how we plan and deliver care, as opposed to just waiting for people to come in and see the clinicians. So that'll be some of that, and I love the fact that we're going to get a whole bunch of comments in here now. Oh yes, population social determinants of health. Thanks, David Walker. I think that's what you're alluding to a little bit around the exacerbating and causative factors and morbidity being outside the traditional delivery system. How do we integrate them? So we need to include them both in needs assessment and in care delivery and design. So as an example, we've seen in mental health populations, for example, that one of the biggest constraints outside the health system for people to be able to effectively manage mental health is housing. There's very commonly an unstable housing among people who have many mental health challenges. And so ensuring that housing is part of the planning table and the delivery options that are available. So when we think about care coordination, that's, have some role for care coordination, but we also have some role for housing. Social providers who can help access and ensure people get access to housing as part of that program and part of the intervention, and monitoring to see that people actually do get that access. In transitions, a lack of support for community physician involvement, absolutely. And so I'm actually talking for ICES tomorrow. And one of the things that we have there is our evaluation of integrated funding models is at the end of the day, there were both medical conditions and surgical conditions. And we felt that the medical conditions were not yet ready for scale. And so we said, go fast with surgical. They are looking good. They can get enrollments. They can plan and coordinate that care. But in the medical area of CHF, COPD, chronic health conditions, that we have not been able to engage primary care and community care providers well enough. And in fact, many people have refused those programs because they had to change their home care providers and their PSWs in order to get into those interventions. And we need to do a lot more work in integrating those pieces together. Yes, the education system and provider education across the board. And, I think the renewal of education, so continuing medical education across the professions, and also I think developing new curriculum for patients and caregivers as well is also very important. I'm browsing through, oh yes, public health initiatives as part of this. One of the things I really noticed about the OHT applications is in the first round of 30 OHT applications, there actually wasn't a signatory clear inclusion of a public health unit. It's stunning. But 9 of the most recent 15 applications had public health units. I think we've woken up a little bit in the past year of the importance of public health. And we were chatting just before this about the COVID response right now and Kingston's challenges, but Kingston is in much better position. And I said, you must have good public health. And you do. And I think that that is essential. And I think that the population health management helps a lot in that regard, as opposed to, these, focused targeted interventions on just acute transitions from acute to home or health links of high cost users. That having public health involved becomes very important. I will say at the same time, a lot of the things I'm talking about in terms of risk for healthcare utilization, in terms of multiple chronic conditions, also are big risk factors for public health issues, such as what we're dealing with right now. I mean, a lot of our COVID patients have multiple chronic conditions, especially the exacerbations. And so thinking of what are their needs, not just downstream in treatment, but upstream in self-management, in safe care, and also in planning. I think those are really important. I'll take one more, and then I got to go on to the, not leave, but move on to other parts of the presentation. Okay, this is Complex Care Kids Ontario. And worrying about the social determinants of delivery, but also need to be tracked. So we absolutely, I hope we save chat, because I'll try and get to the questions I miss after.
Yes, I will.
Great. The notion of having social determinants in the measurement system, and what do we know about them? We absolutely need to do that. We were talking with, and you'll hear a little bit about this, I think in February at our webinar, Northwest London. In the United Kingdom. And we were talking about their population health management approach. And they, in my view, are at the vanguard in the world. And they have, when they think about their population risk segmentation, they have a bunch of diseases. And for each condition, there's only one thing that they watch for. And clinicians had a hard time with that, but they have to look at the population. And they also then include whether people live alone, do they have caregivers? How secure is their housing, and are they employed? This is in their medical EHR. That's where they extract the information from. They don't go out to a survey and do it at the aggregate level. They pull it off the physician's records in primary care. And we need that system. And then they pull it locally. And then for the 2 million people that live in Northwest London, they're able to look at those initiatives. And that's the aspiration. We're not there today by any stretch, but that's the aspiration of how do we incorporate that in all of this public health planning. Okay, I'm going to come back to sharing and move a little bit more specifically to OHTs. And here we go. That was our one interlude. So in Ontario, what does success look like? Well, I was looking for, if you look up paradise, often it comes in terms of like beaches and palm trees. And I think I saw someone in here, yes. I'm not sure your name, but has a great beach, and that looks like paradise there. But it turns out, oops, if I can go back, you can find paradise in the Blue Lagoon near Sudbury, Ontario. This is a video you can go and find, and it's about 40 kilometers outside of Sudbury, and you hike through the bush a little bit, and you find paradise in Ontario. So maybe paradise, and what does success look like? Maybe a little bit different for different people, and it might be local, because I'll tell you, this is paradise for people who can access it in the Sudbury area. So how do we think about what does that look like? We're in Ontario Health teams looking at this from a quadruple aim framework, as I mentioned. So what does that mean? That means that we're thinking about patient experience, we're thinking about provider experience, we're thinking about health outcomes, and we're thinking about cost. And I'm going to go through each of these a little bit in some detail as a bit of a preview of how are we actually really thinking about OHTs, which is, I think, actually what you wanted me to talk about. So The first part was what I wanted to talk about. So here, around patient experience, we actually, about a year ago, before OHTs were being launched, we're thinking about this. We've actually been thinking about it a lot. And we said, in general in Ontario, how would we know if patient experience is good? And so here are some, I'm going to leave out the 175 odd 1 hour interviews that we did with patients and caregivers and other work that we've done over the years to get into developing these kinds, and this isn't comprehensive, but things like your overall healthcare is well organized. It's easy to access the healthcare that I need. Your healthcare providers understand how to help you maintain and improve your health. How confident are you that you know the things you need to do to manage health? Do you have conflicting information about your healthcare? And these get at different aspects. This is not a comprehensive list, but we have four things. Having someone to count on, knowing what to expect, knowing how to access care easily. That these are really important aspects. And these are actually items that we put into the Ontario Healthcare Experience Survey last year to start to get a baseline against which we can compare both Ontario health teams and in general the transition of health in Ontario. On the provider experience space, we've done quite a bit of work in the past year as well, mostly led by one of my colleague and co-lead for the evaluation, Ruth Hall. And through both starting out with existing tools in the provider area, but then also doing a lot of focus groups with providers, everybody from PSWs, care coordinators, right up through to primary care specialist physicians. And here are some example items that we have that we want to assess in OHTs. That first off, the providers feel that patient care is well coordinated with community resources. Also that it's providers themselves at the beginning of their day, as they go in, they actually just want to be able to get high quality care to patients and clients. We said, that's what's important to you. And they said that I can get the care I need for my patients. That's what they said. So actually that pays right into provider experience. But also some other things that, leadership promotes an environment that makes the world they do enjoyable. And in the area of burnout, I enjoy my work. I don't have symptoms. We have other layers if you are actually feeling a little bit burned out, but this would be more optimal of the ideas of some of the areas of provider experience that would be important. We have a survey tool that we've developed and we'll be making available. On the health outcomes side, there's lots of ways we could do it. I'm just going to put up that we are thinking about using the YourQual 5D, 5-dimension, 5 levels, and the 5 dimensions are mobility, self-care, usual activities, pain, and anxiety. Trade-offs and how do you choose measures, but I'm just saying for OHT success, this is what we're thinking about. On the population, that's more on the individual side. On the population side, we are interested in having people pay attention to premature mortality. That's a pretty strong population health indicator. And then we will be resorting at the population level because those health outcomes, at least the EQ5D, we can only collect through direct patient engagement. To get more population, we will be using some proxy measures such as unplanned hospital care. I'll talk a little bit about some of those proxy measures, cost and utilization. So we have thought about this at the outset in two ways. One is overall. So what are some whole population measures we can think about for everybody, or comprehensive measures for anybody that has been chosen as a priority population in the health teams? And then we thought about some of the specific areas. So 3 areas were very prominent in the OHT applications of areas that people will focus on. And so we said, well, we kind of need to make sure we have a couple of measures that are indicative. And we've been doing some validation work over the past year with some of the lead provincial groups that are responsible for Ontario's measurement in these 3 populations. So what are some of these indicators? And these are preliminary ideas. We'll be back at the end of the month with where we've settled on these, but this is probably 90% of the way there. So first off, total system cost per person per month. We need to be monitoring that because that's the cost at which we'll measure our value in the system. Some of the areas that we are thinking about are total acute days, continuity of physician care. We've done some work. I know Mike Green's done some work, others, and we have a new paper actually coming out, and we're still trying to understand how it works exactly. We've previously shown that having high continuity of care with your primary care physician is equivalent to having 1 less chronic condition in terms of your use of hospital care. We've actually now shown that it can lead to about a 10% decrease in the accumulation of new chronic conditions. And that's not just because you're not visiting other physicians, because we've done some checks around that, but continuity of physician care is quite important. In this day and age, we're very interested in thinking about new ways of delivering care through virtual. We can only measure physician encounters. We'd like to measure other virtual encounters, but physicians are what we can measure now. Then, the other ones around other types of acute care, follow up with primary care and acute care. So these are kind of institutionally dominated measures. We do have a good number here with primary care and other physicians to get us out of the hospital. But these are chosen as measures that we can measure on everybody in Ontario. So our rate limiting factor here is what can we measure for everybody across the health teams. And so our overall measures need to be able to do that, as weak as they may be. The second, I'm just going to quickly go through some of our early thoughts in these other areas, or, well, reasonably advanced thoughts, I think. But mental health, your first time we found out that you had a mental health concern was when you ended up in the ER. That's not a great way of planning care. And then there are a few others that are primarily hospital-based measures that we can measure reasonably accurately, mainly also because we don't have very good coding of mental health conditions elsewhere in the system that we can measure reliably. In the area for older adults, we have only one hospital-based measure here. And we had some help and advice from the Provincial Geriatrics Leadership Office. And one hospital-based is multiple fall-related ER visits. And the other ones actually we're getting at, because they really said you need to be looking at people's health. So we are going to be limited here to people who have had assessments because they're receiving home care or have applied to or are living in long-term care settings. But for now, we're thinking that we have these data provincially available. We should start to use them and get people to think about outcomes. So health-related quality of life, physical function, cognition, and caregiver distress allows us to get at not only patient experience, but as weak as it is, we actually have a whole caregiver tool, but we don't know how to deploy it yet. So for now, it'll be this. And then end of life, working with the provincial office around palliative and end of life care, place of death, home physician visits, number of days at home, and ER visits in the last 30 days. So these are some of the sort of harder indicators that we're thinking about when it comes to measuring how we're doing with Ontario health teams. So I'm going to pause there, and I'm going to ask three things that I think are worthy of conversation here. And one is, what do you think about this quadruple aim framework approach? Are there other things that you would think? Do you think that there are areas of measurement that would be widely available across currently 45 teams or 42 teams approved that we should be measuring because the data are available? Not the things we'd like to measure, but the things we can. And the last piece is around everybody's actually put in local measures of performance. And anybody who's asked us, as they were putting together their submissions to the ministry for the funding agreements, what indicators should we pick? And I have said, pick the indicators that are most meaningful to you, that you will know how well you're doing on implementation and success in the next year. Don't rely on these large administrative data measures. So I'm going to turn off the screen and come back to the chat a little bit, and come down and say, and look here, I'm actually just for a moment going to read up bottom up. So David Walker's asked, do we have the digital infrastructure required? We have it in places and we're building. And we've actually been working with Ontario Health a little bit lately. Ed Brown's got a new group and initiative interested in supporting population health management across the province. And for example, building on things at the local level for population health management using registries through groups. It's happening in some places. Ontario MD's done quite a bit of work in their space with the people signed up with them. And I know that there are some other initiatives that allow us to do population health management. I will say that the people that connect with the population are the primary care physicians. That hospitals only interact, thankfully, with a very small proportion of the population. Even home care only interacts with a small proportion of the population. The people that actually see everybody is primary care. And that's where we need to put our efforts and energies in terms of creating consolidated ways of leveraging that data. Quadruple aim, yes. And coming back up here, Yeah, some slides still having a high hospital focus and needing to think about how community makes a difference. And we're going to continue to move towards this. Our biggest gap here is that we don't have a lot of individually collected data from people in home and community care, or not just home and community, all of the community resources and services. So people access a lot of programs, day programs, community mental health outreach, and we don't track those in a systematic way and enable access to them at an individual level that we could actually link to other types of healthcare. So this notion of a universal ID. OHIP numbers are not used for all care. Social services don't use OHIP numbers. Education, when you're in the community and in the schools, we don't use OHIP numbers. So either forcing people to use that or adopting some other universal ID is essential to allow us to do a better job of population health management, frankly. And that's continuing to move towards that front in every way possible. Joy Hatley, think I'll look forward. Feel free to reach out and tell me about filling in the gaps for patients, because we still think about gaps where there are we could do better for people, and we know we can measure that we could do better. Yes, there are best measures for health, and difficult to actually. Practice-based learning networks are a very important area, Mike. Yes, absolutely, around leveraging those primary care records, and SIPSN, which also has a home at Queen's in terms of one of the national leads. So there are people, but you know, I was talking to somebody. I was at the skating rink yesterday, the one thing we could do in Toronto, and talking to a criminal lawyer. Happened to be out with her kid, and she said, you know, we advanced criminal law in the court. She goes, yeah, administrative, that was okay, but criminal law, 10 years and 2 months. I would like to see us do something like that for OHTs, where we could say we advanced digital healthcare capture in primary care 10 years and 2 months. So let's hold that out. And I think there was an earlier webinar where I think it was like, no facts free by 2023. I think I heard that on this program. So that's a start, but that's not really that ambitious. We need to be much more ambitious than that. There's no solid population health management program in the world that does not have digital data on their entire population available at scale. So if we want to do population health management, we need to do that. Like, you just can't do it without it, frankly. People agreeing and supporting that, I think. So, you know, we have said, and we're going to continue to say, that if we're still measuring the same things in 3 years, we've probably failed. That we're using what we can now, but we don't plan to measure something in 3 years because it's what we measured 3 years ago. We're going to move as we advance to better measures with better data, because they're the right measures, they're the right things to be watching for. And that, I challenge everybody to take a similar approach. Okay, I have to be a little bit conscious of time. Last section. It's going to take time to get there. That's all I'm going to say. Are we progressing? So this is, you know, there are lots of frameworks. This is one that I refer to around, it can be applied to population health management. There's a lot of things about integrated care that are related to population health management. I'll say you can do integrated care without paying attention to population health management in any way, but you cannot do population health management without thinking about integrated care. So here is Merle and Minkman out of the Netherlands. The Netherlands are, you know, sort of at a population level. They've been thinking about this for a while. Lots of things you need to do, you know, client-centeredness, quality care, delivery system design, performance measurement, results-focused learning, commitment, roles and tasks. These are all things we're talking about in the OHTs as well. And that there are multiple phases. You don't just arrive at success right away. Initiative and design, I think that's really where we're at today. Moving in the next year or so into experimental and execution phase. Beyond there, we're going to be thinking about expansion and monitoring. To me, that's as people start to move from their priority populations to their next priority populations, that's where we get into expansion and monitoring. We've actually started to think about these two things. And then we'll be thinking about consolidation and transformation. So there's phases to these, and we are at the early days, frankly, of this initiative around OHTs. We're just beginning of the journey. And so the question around how would we know if we're progressing towards this quadruple aim goal? Well, we can lay out our baseline on those quadruple aim measures, and that's what we'll start with, measuring them as best we can in the first year with some historical context. But one of the things we know is that we need to have the right resources, the right people in context, and the right activities that are happening now to set us up. And our team and some other very bright graduate students had done some work around what we needed for integrated care. And as I said, there are relatable things that you needed some basic structures. Then you also had to have the right people and values around leadership, clinician engagement, patient-centeredness and engagement, organizational network culture, and then you have to have some key processes around partnering and really developing these trusting relationships. So we use this as a background to run our survey of all OHT applicants. And so just the people who had been involved in those application processes is where we started. And I'll just say that we've also seen that these map to the common parlance in the Ontario Health Teams initiatives around these 8 building blocks. So these map into these 8 building blocks as well. I'm not going to spend a lot of time on that, but just so you know, there is a clear link. So here's what we found, and this is from this particular graphic is in our report that's online from the first 30 teams. And we did this for all applicant teams, not just the approved ones. And you can see strengths and weaknesses across the province. We stratified this out, the overall, where the 90th percentile or the better teams are doing things. And even the better teams, you see a similar pattern overall. Leadership approach, shared vision, team climate, these are very strong. Down on the bottom, commitment to improvement, one of the strongest overall. People are committed to doing this work. Where do we see weaknesses? Financial and other capital resources on the left, and over on the right, also in the clinical and functional integration. So those are actually, clinical functional integration are around the tools for sharing patient information across providers. That's where we find that. And that's the ability of the primary care doc to see what happened in the hospital. The ability for the allied health professional, the physiotherapist or occupational therapist, to know what happened to the person that they were caring for in the home that they're now doing an assessment on. They actually have very little information except what came through the referral. So that access really needs to improve. So the top domains here, and I've turned these into percentages because I think you could relate to these, we're sort of 84% achievement on commitment to improvement, which is pretty good. My kids come home with a grade like that, I'm like, I'm not going to complain. But over on the right side, you see the areas: change readiness, administration, team climate, good. Financial and capital resources, very weak, 52, not acceptable. Non-financial resources, a little better, and that's more about in kind and having the right people to do the jobs in the hospital and in the other parts of the healthcare team around the organization, the delivery, the communication. And finally, this area of clinical functional integration, that would be a failing grade at my university. The last thing I'm just going to say is, how are we going to progress on these? And I'm going to say it's going to take time and space. Some people are further ahead, and I'll indicate that in the next slide. We need trusting relationships. We've learned that from HealthLinks, and we've learned that from integrated funding models. That's where those pieces come in. And how well are we able to apply that? We need to build on experience and existing partnerships, and it will take time to be an overnight success. Don't be too patient, but we do have to be a little bit patient here, that we need these relationships. And here's one quote from our interviews. We did over 100 interviews, about 108 interviews with the first set of teams. And here's just one that I think points to this, and I'm going to call this 4-dimensional thinking, because this is where we need to think about time and space. And working through the trials and tribulations, getting people to take off their organizational hat and look through a different lens for the common good of an integrated service delivery model and a population health model is something that's already been worked through in this particular team over several years. So they are prepared to step forward because they have been working on it. And we need to continue to expand. We need to continue to include public health, more community-based providers that haven't necessarily been at the same tables before, community mental health associations, other types of housing providers, in order to advance the OHT model. And that will continue to evolve. And we call this the, you may have noticed my terminology was around the quadruple aim as an improvement framework, because we're going to constantly need to improve. We're not going to arrive at successful OHTs in year 2 or year 3 or even year 5. We will need to continue to build towards population health management and integrated care. We have lots of conversation in our team. What does success look like, and how do we know if we're getting there? I really like, some of you may have met our cultural anthropologist working in our team's evaluation, Gaia. Boldania. And, I really love the way she phrased it. At this early stage of development, the OHT model has become the peg upon which the hopes for many system reforms precariously hang. We don't have a lot of options in the bag right now. OHTs have been enacted by legislation. OHTs are the way that we are focused to transform moving ahead. And be ready. We are not going to completely succeed in the first round. And as we fail, we just have to try to make sure we fail forwards so that when we get up, we're further ahead than we were in the last time. And I'll say, I mentioned earlier, Northwest London being really at the forefront of this. And one of the questions I had for them the other day was, I first got to know about Northwest London. Here's how you can find our reports and contact us, follow us on our Twitter, or reach out to us anytime you want. I said, I've been watching Northwest London for about 10 years in their early days of integrated care initiatives through their pioneer models and now their whole systems integrated care. That's what they call whole system integrated care. And I'm like, every evaluation I've read about you guys has been a failure. You've all failed. You failed your patients on patient experience. You failed to have readmissions. The most recent paper is how commissioning has failed yet again, the payment models. How do you keep moving forward? And they're like, really committed people, expanding the credibility amongst other strong local leaders, and that the NHS has been right behind integrated care and advancing it, continuing that is where NHS England is going, and they're going to be lockstep. And even though every political party changes what they call it, they continue to advance from the national level and expect people to deliver at the local level. So those are kind of the comments that I had, and remarkably good on time, actually. So there's an outcome base, and now we've got time to chat, and there's a lot in the chat, and some great ideas, and I'm looking forward to reading through and specifically answering back and learning. There's people putting in links that I'll be able to follow up on later, and understanding. So yes, we really have to think about the shared accountability and moving people towards things that are shared and not just individual. And one of the, all kinds of anecdotes come out. The government's going to have to create some space here. If everybody is just off running their own little accountability agreements, their MSAWs or their HSAWs or whatever type of SAW they have, that is only accountable for things within their own area, we need to maybe change some of those, drop a few, and move towards a couple more that are shared. Our health system performance network, just as a remote example, we actually started out as the hospital report card back in 1999 with Ross Baker, and it came in response to a news article about crappy quality care in hospitals. And so they created a hospital report to put out performance measures on just acute hospitals. Then they expanded and said, okay, emergency departments. Then they expanded and they said rehab hospitals. And then they said chronic care hospitals. And then they said mental health hospitals. But all these separate reports for separate parts of the system. And one of the things that I came in and with colleagues, people agreed that we needed to move towards system performance measurement. And we needed to start thinking about this at the patient level and stop thinking about it at the provider level. And what I said to our team, which is backed by a group of investigators, was that we were not going to do any projects that only involved one provider. That in order to move ahead, your research had to involve multiple providers and it had to track patients across multiple providers. Go forth. And we did not fund, we have not since that day funded anything that only concerns individual provider groups or one sector. And we just continue to work at it. Do we have a great system performance report card today that's integrated across the entire system? No. Are we doing better? Yes. And that's where I think we have to continue to acknowledge, improve, fail and fail forward. Yes, at person level, beyond the patient level, is the way we need to be tracking our outcomes and our quality. Any other comments? The chat's been active. Sometimes people come off mic here, so I'm going to open it up. I don't know, maybe hands or people don't want to jump in. People sometimes feel like everybody's going to jump in at the same time, but then nobody does. Okay, I see a hand, but Nora.
Nora.
Just wanted to speak to the challenge of measuring more of the patient-focused outcomes and look for those outcomes that you could use to evaluate OHTs for everyone, while at the same time having them be relevant. That's a really big challenge on the patient importance side. And so I'm just going to speak to that because it's my area of focus, and say that what you're seeing in terms of challenges finding those measures is right on par with the scientific community. And there's a paradoxical challenge that a lot of the measures that have good data behind them were also developed on the population that were the 99% that you didn't see in your original chart. So you had that 1% of the population taking up, requiring about 33% of the resources, and the measures weren't validated on those people, and the data isn't driven by those people. So it's going to be a challenge for all of us measurement scientists about how to get the right measures that are applied to those people, to the 99% and the 1% at the same time. So you can reach out anytime.
Yeah, thanks, Nora. So that's where, we have said to OHTs, it is so important that you have patient-centered measures, and it's so important that you focus on your local area. That don't ask me to tell you what we're going to measure from an evaluation perspective at the provincial level, because it's actually not the right measure for you. And I just don't have the power to do what you can do locally. So do what you do locally.
Walter, I'm just looking at the time here, and we just have a few minutes left. I don't know if anyone wants to have one sort of oral question or comment they want to share with you. I see there's lots of different people here that I'm sure would have lots to contribute right now.
It's David Walker. If I could make a comment first and then ask a question. Walter, this has been fantastic. For those of us involved in OHT development, this has been very elucidating and very well done. I'm not familiar with the Northwest London initiative very well, but I'm also, as I said in my chat, intrigued by how you pull people together to become accountable, shared vision, shared accountability, shared commitment. But in the end, places like Northwest London or Canterbury in New Zealand tend to be people who are paid by one organization and accountable to it. I suspect in Northwest London, although they do a sort of purchase of service agreement stuff, there's more of a command and control situation. And we have the issue here in Ontario where we have, well, certainly Southeastern Ontario, 90 community service agencies who are all laboring hard to understand what's happening and what they're doing. And we have family physicians who traditionally have not been well coordinated or integrated, let alone everything else. So I am intrigued about how we get through that. I mean, we can be collaborative all we like, but sooner or later, we're going to have to join the Maple Leafs and be a team player rather than each have our own coach and owner.
Yeah, and we could have a debate about whether the Maple Leafs are enough of a team playing organization.
Maybe
actually, that might be the thing that's their problem. And yeah, eventually we're going to need to get rid of organizational boundaries that we have now. We're going to have integrated structural organizations. People will be more trusting to move into that once they've been working with the people on the other side, I think a little better. But there is no doubt that we can't have the number of organizations that we have to partner, and the transactional costs alone will just be outlandish. We just need to, and trust is to me the efficiency by which we counteract transaction costs. And people will have different titles, and there won't be 17 CEOs in one OHT. There will be fewer. There will be fewer boards. There have to be. And I say the biggest barrier to me, and the thing that keeps me up at night, is physician engagement. Because we don't even have an organized entities, except through some groups like family health teams, and we need to organize physicians across the province so that there are, at least for each OHT, representation for physicians to be able to come to the table as an important party. And I chatter back and forth with the team on the weekend, I think for OHTs to be successful, we need physicians at the steering wheel. We need hospitals as the engine of fuel. Perhaps the government can have a bit of fuel, and patients need to be on the gas. And that's how we'll actually advance this program.
Thanks very much, Walter. And thanks to everybody. I'm just looking at the time. We're just at 1 o'clock. And I just want to say, Walter, how grateful we are that you came and joined our area. And you can see that level of engagement and interest in this. And we are highly committed to our OHT here. And, just thinking about that last quote, our OHTs are the peg upon which we rest our hopes on. So I'm sure this conversation will continue, and we'll be saving the chat and sending this out and posting it as well. So thank you very much for the excellent presentation and everyone who participated in the conversation today. Thank you very much.
Appreciate it. Thank you very much. Have a good day, everybody.